Thank you. It's good to see everyone here, despite last night's fun and games. And Vaughan? I've got to warn anyone who's sitting in the front 2 rows, I'm going to pick on you this morning, so be careful. Sue, you're very brave. Okay, this morning is a very important talk, I guess, in a way, to think more about the way in which we deal with patients, the way in we handle them, the way in which we communicate, and the way in which we encourage them to have a good quality life and show what can be done. So this morning it's about how you can make a difference to those patients you're going to be seeing. And it requires a little bit of extra touch sometimes, a little bit of extra time, which is always valuable to us all, but nevertheless it can make an important difference to us. I do lots of different things and that's boring. What I'm going to do, I'll give you a PDF of all the things of this talk and my talk the other day if you want. I'll make it available through the BLS and you can access the PDF, so you don't have to take notes, and there's no exam today or assessment, so you're all looking good. Now, as I mentioned in the talk the other day, I want to emphasise that lymphedema, we're dealing with a unique problem, okay? We've got a unique individual, we've got individual needs with functional, social, psychological, whatever, and they vary with time from the moment of diagnosis or even before a lymphedema is picked up. There may be these problems pre-existing problems. These pre-existing problems may be linked to other conditions, and that's why, as you'll see a little bit later on, a differential diagnosis is important, because sometimes you're lumbered with a patient with all sorts of other problems as well, not just the lymphedema that you're expert on, but a phlebedema or a lipedema, and someone else can maybe help manage that initially, so we don't have to worry about those issues in terms of the way in which we deal with our patient in front of us, because we're interested in the lymphatic issue. Other people can solve and sort out all sorts of other problems, as you'll see, before them. And as yesterday, we want to be sure that you're aware that we tend to get focused on lymph volumes and lymph circumference changes, and no, that's not the only thing that changes. That's not the only problem. That's not the only important thing that we should be thinking about and dealing with. And I guess this is my key message, and I've emphasised the key bits in red. I'm unique, you're unique, they're unique, and what we have to acknowledge is that they've got unique specific components to their problem, maybe a specific lymphatic territory, maybe a specific pathway, but they've also got specific requirements associated with that, and we have to tailor our communication and our needs with those. So I guess one of the first things is establishing a relationship. And I guess, you know, who's been shuffled around from one health professional to another with another condition of your own? And, you know, and there doesn't seem to be any communication between them. There doesn't seem to be any continuity of care. And that really affects us. It affects me when I've had those sort of situations. And can you imagine how it would affect a patient with a chronic condition like lymphedema, they knowing that it's going to be chronic? So, yep, it's necessary, but what we have to try and work towards is consistency and continuity and input. And the idea behind that is the best outcome for you in terms of your satisfaction of showing that you can make a difference, and for them in terms of appreciating and having the ability to experience an excellent outcome that you've offered them, and that can make a difference. And I guess the other thing, I've seen many people provide information to patients, and the patients have no idea what's going on, okay? So it needs to be at a level they can understand and relate to their presentation. Here's an example of a cartoon out of a book, where the GP here is talking about lymphatic transport capacity. Absolutely great. Who knows what it is? We all know what it is, don't we? No sweat. But, you know, does the patient know that? You know, is that the right terminology to use? So it's just a request to think about those sort of things. And what we have to always do, we have to do things appropriately, consult the best practice guidelines. And in Australia, we've now developed what's called a pathways document for GPs and specialists. What they can do is go, who are not knowing about lymphedema, they go into the pathways document and it takes them along a particular pathway. So identifies red flags and all those sort of things along the way and sends them all out in a dichotomous series of things to do. But we have to come back to the patient as an individual, okay? And that's why I was a bit negative yesterday about RCTs. They don't show the patient as an individual. And I'm just going to pick on Vaughan in a minute for that, perhaps. I guess the other most important thing is be part of a treatment management group, okay? Communicate and share outcomes, the good and the bad. And this comes down to writing your case workshop, your case studies. We need more case studies. Every time I speak to groups of therapists like you, I ask, how many have actually written and published a case study? Might I ask you now that embarrassing question? Okay, that's wonderful. There's about 9 of you have published. And yet we've all got some incredible information. We must do it. And I'm going to be negotiating with the Journal of Lymphoedema to see if we can get a whole issue out on your case studies. Now you know how to write one. You've been to the workshops. Okay, you know how to write one. You have to do it because that case study is the beginning of new knowledge, new information, new directions, or whatever you want to think. And it's acknowledgement. It'll lead to a better acknowledgement of the problems that our lymphedema patients are suffering. So please, please write it up. We're all here to help. Even I'll help you write it up if you're having trouble. Okay, but that's our aim for the present. Get these sort of things going. We have to encourage our patients to ask questions or ask them about their worries. What's worst? What's the worst thing that they can happen, and what might be the best thing that can happen to them? About their range of problems, about their local support. What have they got where they are? And in Australia, they might be sort of 150 kilometres away from the nearest centre, you know. And that's why we run screening programs back where we are. And Margaret, you've been to a screening program, and I think Vaughan's been to one of our programs. And they go out to those people and help them in where they are to inform them and help inform the practitioners and the like. And also need to know about, you know, what's there for them, the family, the carer, the patient support groups, and what they'd most like you to concentrate on. So sometimes we say, oh, well, let's work on the leg or the arm volume reduction. No, it's not what they want. They want something else. So I guess, number one, you have to enjoy every moment in what you do, okay? And the day you wake up and you don't enjoy what you're doing, get out of it, do something else, go fishing. So, what you need to do is accept and appreciate the benefits and life changes you can offer the patient if you know them, you know what they want and those sort of things. And I guess, as everyone's mentioned, we have to be holistic in care of a lymphedema patient because, you know, all the fluids and the lymph from the legs goes through the abdominal area, thoracic area to the left shoulder, okay? It's a whole body issue, okay? Not just then and there in that picture, but it's a whole body issue for their life. And, you know, a good functioning lymphatic system has no hydrostatic pressure because each lymphangine is 1 millimetre in length. You saw Dom's lovely pictures the other day of functional lymphatic collectors. Yeah, they can be made to work, okay? But the smaller ones can't if they're showing dermal backflow. Pressure in lymphatics is low, okay? During obstruction, some lymphatics can pump strongly, as the work of Peter Mortimer and Stanton showed with occlusion cuff plethysmography. People who get lymphedema don't have as high a pump pressure, generally, as those who don't get it, okay? So that's the reason, could be one of the reasons. So, you know, be holistic in your treatment, your care, your management, and your identification. Why this holistic picture is we need to empty the buckets. I guess it's Pascal's law. Fluid flows down a pressure gradient, okay? And our pressure gradient exit point is the lymphatics at the ductus thoracicus junction of the subclavian up here, or the right lymphatic duct, and maybe some other places. So what we have to do is be very clear that we've got somewhere for the lymph to go and the contents to flow into. Super, super important. Sometimes we forget about it. Sometimes we forget about clearing those proximal areas. And nowadays, back home, we're very, very strong on encouraging patients or practitioners to clear the proximal areas before they doff a garment or before they take off a garment, okay? Otherwise, you've lost the benefits of that garment. And as Vaughan showed quite rightly, if you don't do something after you've done MLD, within 20 minutes, you've lost the benefit, okay? So you have to be a quick responder, okay? So if you want your garment to get a better outcome in terms of fluid movement or circumference reduction, if that's what your aim is, you've got to clear out those proximal territories so the fluid can just pile out relatively easily and quickly. The other most important thing is a full assessment. Super, super important. And maybe a patient will come to you with that full assessment. They'll know about all their medical history, their family history, medication history, and, you know, with the CCTs now, channel blockers and stuff like that, you would have seen Vaughan's presentations on medicines and their problems with the lymphatic system and the gut and all those sort of things. You know, it's very important to recognise that because all these other things, someone else may be able to deal with those problems and make a difference. A tweaking of the medication, for instance, can make a difference to the lymphatic load or lymphatic function. You've got to think about those small things. Other important point is the full assessment may expose other reasons why the limb might be swollen: thyroid problems, vascular problems, blood pressure. Okay, from what we gather, every 10 millimetres increase in systolic pressure gives rise to about a 10% increase in load on the lymphatic system. Reduce the blood pressure, you've solved some of the load problems. Genetic issues, liver and kidney diseases, and then activity, occupation, BMI, and all those sort of things can be a problem, and a slight tweaking of them may be able to make a difference to those people. Proximity of veins is an example. I mean, I work a lot with the Australasian College of Phlebology, because phlebologists don't understand about proximity relationships with lymphatics and the damage and problems they cause. And here are some of the issues and problems that can occur with carryover of diseases or disorders. What's that thing buzzing around?
It's the cursor.
Not me. Okay, anyway, so there's a whole... You guys doing it over there, are you? That's strange. Anyway, don't worry. But there's lots of things that can happen to lymphatics from the vascular system. I'll get out of that slide. That's amazing. All right, now let's have a look at normal lymph collectors. Okay, so from an arm, around about 5 mils per hour. Okay, from a leg, about 20 mils per hour. Okay, it does vary, but that's on an average. And what the message to get across to patients and for you to understand is, it doesn't take too much difference to actually change the lymph load or the lymph flow. Okay, that's 5 mils a day. And I always use the example, if I've got, this is rude, I know, but it's not meant to be. If I've got a problem here in my nail bed and there's 5 mils of extra fluid accumulating in my finger on one day, do I know there's 5 mils in there, the finger and the hand? No way. 5 mils a day for 5 days or 7 days, 35 mils. Do I know there's something going on? Yeah, I'm beginning to. And if you put it on, let it go for a month, 140 mils, okay? Then I know I've got a serious problem. But you know what it boils down to? 5 mils a day. That's where you can make the biggest difference, and that's where the patient can make the biggest difference by knowing that sort of thing. And that can link to skin quality, blood pressure, strength of small blood vessels, infections, weight and fat in the diet, issues with veins, and all those sort of things. So, has everyone got that picture? Little things make a huge difference. Get that message across, and you're looking better. We also need to be sure... Margaret, I started late. It's not the true time, is it? Good. Oh. It says I've only got 15 minutes to go. There's no way I'm going to stop in 15 minutes. Cool. Okay, so we and everyone has to be aware that simple events may slow lymph flow. Bloating. Who's bloated? You know, have you looked at your veins when you've bloated? How engorged they seem to be in your legs? Okay, that's just bloating. Imagine what that's doing to lymphatics. Okay, constipation. Okay, so a change in diet can make a difference. Mesenteric fat, yellow fat, becoming an alarming problem lately in some individuals. So that can make a big difference because it doesn't allow good mesenteric lymphatic flow, or it doesn't allow good movement through the abdominal cavity as well. Shallow breathing. You know, we've done some work. Vani Prasad has showed us that when you breathe in deeply, yes, you can clear lymph using indocyanine green from the larger lymph collectors in the breast, as long as they're functional. So breathing can make a difference. And the other thing, constant external pressure in the wrong place. Okay, if you've got a pressure transducer and you look at bra strap pressures here, they can sometimes be up around 20 or 30 mils. If you look at the area here, this, according to Laplace's law, has got the strongest radius of curvature. The pressure is highest here. And what goes through there? Lymph collectors, your main ones. So if you've got elastic elements in the groin or around the tummy and places like that, it can be a serious problem for you. Simple things make a big difference. Adjusting that bra strap, adjusting the elastic can make a big difference. So, simple actions can help lymph flow, okay, as well as influence lymph load. Okay, this is deeper breathing, isotonic, isometric muscle movement, general movement, self or partner massage, massage pads, electrical stimulation, particularly for those immobile people in community health centres and the like. Emptying the buckets before donning or doffing, like I mentioned, is really, really important. And, most important, having a look to ensure what you can do, what the patient could do, to ensure mesenteric lymphatic loads are low in the night when they're lying down, when they're horizontal, when they can have good lymph flow from their legs or their arms, okay, if it could get through. But if there's a big mesenteric lymphatic load, because they've had a diet which is rich in materials that got to be absorbed through the mesenteric lymphatics, it ain't going to work as good as it could, okay? I remember my mum used to say you have breakfast like a queen, lunch like a princess, and evening meal like a pauper. And, you know, that may work for those with lymphatic problems. So, key messages are assess and undertake early identification of changes, okay, in the limb. Undertake early intervention. Now, this blue bit here is probably the most important thing I'm going to tell you. It's about, you need to look at targeting and sequencing treatment. Okay, there's no point trying to do lymphatic drainage massage or manual lymphatic drainage if there's lots of fibrotic induration or if there's dermal backflow like Dom was showing. Okay, you've got to make sure you've got some functional collectors to clear it through. Otherwise you're wasting your time and the patient will get disillusioned, you'll get disillusioned. So you have to do targeting and sequencing of treatment. Sorry, just go back a bit. Okay, so most important thing next is make sure that they've got knowledge of a role that they've got to take, or their partner or carer, and how they can help. You know, it's independence. They're not seeing you for 2 or 3 months. What are they doing during that time? And one of my PhD students is now working on that, having a look at the way in which you can encourage communication, even though it might be automatic. A reminder phone call saying, what have you done today? Have you done what you were supposed to do today? Just a checkup. Takes about five minutes sometimes at most. Or it can just be a robocall sort of thing. So the most important message all the time, thinking, assessing, treating and managing holistically. That's what's unique about the lymphatic system. The other most important thing that's there for us is that, you know, we've got a current group of patients with lymphedema, with our lymphatic problems, that might have progressed along the stages of lymphedema. They may be in stage 3 or something like that with lots of induration and lots of fatty depositions, okay? Fine, we're doing that. But then we've got our new group, those people who are at risk of lymphedema. And that's what we're all about, is the next group coming through that we have to be proactive in them, okay? Our future is here, our patients' future is here because we don't want them to get lymphedema, we don't want them to get to the stages of lymphedema that we find the older groups are at. So, coming back to the basics again, number 1, early advice we know can reduce lymphedema risk, super important. Okay, once we know the risk factors. Early signs of lymphedema, we can detect them. We've got all those wonderful bits of equipment out there to detect it. And we know early intervention is absolutely fantastic because it can reduce the severity of the lymphedema, the progression of the lymphedema. So that's what we've got to be doing in terms of our proactivity, the way in which we're looking at approaching the new group of patients, because we want to slow it. And I guess that's the other message that's important. Even if we slow its progression, it's a big win for the patient, okay? We don't necessarily have to stop it or reverse it, but if we slow it, that can be absolutely fantastic because we know generally it's going to be progressive. And I guess in Australia at the moment, we're interested in these things and how they can reduce the healthcare system and patient costs. Now, I guess this is what we spend a lot of time dealing with, the at-risk groups of lymphedema. Looking at the risks and assessing them and minimising those risks. And remember, it might come down to that 5 mils every day. If we can just do one thing better, reduce the load on the lymphatic system by 5 mils or clear 5 more mils out, we've solved the problem, okay, on a day-by-day basis. And here's the sort of risk assessment forms that we use in Australia. And I think Yvette or someone over here is using some of our risk forms, as are the ones in Canada and the like. But these are just ones we use in the screening programs. And, you know, they're not absolutely perfect, but they give us a good indication of what's going on, what the risk factors are, and, importantly, which the variable risks are. What are the controllable, the manageable risks that we can deal with? The other most important thing is to use, whenever possible, objective diagnostic techniques. And you've seen all these, and you may be using some of them. ICG, lymphoscinograms, TDCs, tissue dielectric constants, bioimpedance spectroscopy, and importantly, these last ones, stemosine and the pitting test. You know, there's nothing wrong with those 2 tests. They can give you a semi-objective measure of your lymphedema. The amount of the fluid, where that fluid is, and the amount of fibre in the tissue in the case of a stemocyn. Who actually uses a stemocyn here? Great. Who uses it just in the toes or the fingers? Okay. Who's actually ever used it in other lymphatic territories? Okay, and it's, yeah, put up your hand, I'm curious. That's great, that's good to see, because that is really important, because that can let you know what's going on in each individual lymphatic territory. Gives you a feeling, shows the patients what's going on, and allows them to do that sort of thing at home, okay, in a gentle fashion. So, nothing wrong with those two tests. Now, the other thing is we need to make sure we've got some qualitative health assessment measure, and the LymphQual, as you know, Vaughan's LymphQual and some other instruments that are around for head and neck nowadays, translated into various languages, and for legs and all those sort of things. Please use that, because it's a balance between quantitative and qualitative. Okay, you need to look at both sides of things. Now, the most other important thing is assessing and knowing the compliance or adherence of our patients to our requirements of them, okay? And what we have to do is accept what they can't do and focus on what they can do, okay, to give them that sort of positive. And point out small victories in treatment, okay? That's really, really important. I'll just go back to that slide again. And I guess, like I emphasised before, just indicate that slowing or halting lymphedema is absolutely fantastic for us and for them as well. Now, our goal, I guess, as the debate was yesterday, I don't like the idea, many people still say, oh, let's wait and see what happens. Let's see how it develops. Come back in 3 weeks or 6 weeks or so, let's see what happens. But, you know, I don't like that idea, because what I like is we've got some data. It's not perfect. It may not be the perfect RCT, or it might not be the perfect information about that patient in front of us, but this is the information. This is what it looks like would be a good idea to do, and here's what we recommend, and here's why we recommended it, okay? And that's where your case studies are going to come in for us to help us and help you in the future change things as to from what they are currently. So how can you be comfortable? You don't see your patient in an RCT. Who's seen their patient sitting in front of you in an RCT somewhere when you're reading the inclusion criteria, exclusion criteria? It's rare that they're there, so just be prepared for that. The other most important thing is looking at all of these things, important things to help your patient live well with their lymphedema in the maintenance phase, encourage control, partnerships, listen to what they want, size, improvement in how the limb feels, better ability to undertake activities of life or improve function, or whatever, and know what they can or can't do or won't do. That's really important. And our plea is always, well, our belief is do one thing different at a time to that patient. Introduce one new thing. See what sort of result it gets. Show what sort of result it gets. And then if you think you can do better, and based on the information you've got or their needs, add something else to it, okay? And then see how that goes. Then add something else. But don't go on bunging in about 20 or 30 different things all at once, because you don't know what's working, and it's wasting their time, your money, and maybe not getting a much better result. Here's my last couple of things. Please publish and present. I'll help you in whatever way. How long have I got, Margaret? Really? 5 minutes, yeah, okay. So, you know, publish or present. Please, please, please. I'll help you in whatever way I can to get you published in your case studies. There are rules for case study presentations, and you would have talked about those in your workshops. Do that, and you won't get your case study rejected. And if we've got enough, like I said, we'll get a whole issue of the Journal of Lymphoedema going on your case studies to help you move on and improve knowledge around the rest of the world about what's going on. So, like I said, thanks for listening and thanks for watching. And I'll send a PDF of this out for everyone who would like to have a read of it. Thank you.
Thank you for joining this discussion today. It's a great pleasure to be joined by Professor Neil Pillar from Flinders Medical Centre in Australia, and to have this discussion with Anita Wallace from LSN and some other members of BLS and LSN. And we know that Neil is passionate about patient empowerment, about self-care, and we're going to be talking about some of the issues that patients raise or that practitioners perhaps find that patients don't understand very well or prevent them self-caring. So I'm going to ask Anita to say hello first and then the rest of the panel.
Hi, I'm Anita Wallace. I'm chair of the Lymphoedema Support Network and I'm also a lymphedema patient.
I'm Rachel Hutton. I'm a shared team lead for Bath and North East Somerset Lymphedema Service and also a BLS trustee.
Hi, I'm Karen Freer. I'm Chief Executive of the Lymphoedema Support Network.
Hi, I'm Yolanda Borthwick. I'm a BLS trustee and I work in Central Scotland as a lymphedema specialist.
Nice to meet you all.
Thank you.
And you.
Nice to meet you.
And thank you for having me here in lovely United Kingdom.
So I think the panel have a number of questions for Neil.
Excellent, lovely. I'm happy
Yes.
to respond.
Neil, it's becoming more obvious that lymphedema makes it far more of a challenge to lose weight, and yet doing so can massively improve the situation. So how can we encourage and support people on their weight loss journey when those around them, say at slimming clubs and whatnot, will inevitably have a much better response to diets? So that's going to be disheartening. How can we overcome that?
It's a pretty hard thing to do, but the most important message to get across is that without treatment or management, lymphedema is going to progress generally. And if they can, no matter how small it is, what they can do in terms of dietary change or the composition of their diet or when they eat something, that may have an impact on their weight and it may have an impact, therefore, on their lymphatic system's ability to work. And I guess we all know that the lymphatic system has within it all sorts of waste products, and it has in there products in the lymph that are taken away that will stimulate the deposition of more fat if it's not working properly. So anything a person can do to get that lymphatic system working a little bit better by getting it to have a little bit less compression around it is going to make a difference to what's called a lipogenic factor, which is going to stimulate more fat deposition. But yes, it's harder to get rid of lymphedema fat than it is to get rid of normal epiphyseal fat. It's similar. In fact, it's pretty much the same, but there's a different issue because your lymphatic system's not working properly. So those chemical messengers in the tissues and in the lymph are saying deposit fat, hold on to it. And then you get the pressure on the lymphatics.
Yes.
But every little difference in terms of diet, when they, like I said, when they might eat something or what they might have in their diet, according to a dietitian recommendation, may make a difference to that. And the first thing to look for is does it feel a little bit different? Okay, is it sensationally a little bit different for them? And then they may say, oh yeah, let's keep on doing that, and they can keep a record of it. We encourage people to have a daily diary in those of what they've eaten, when they've eaten it.
Yes, that's a very good idea.
And to look for the leverage point.
Yeah, so maybe focus less on the numbers that the scales are showing and more on how you're feeling.
Yes, it's not the numbers, it's the composition. It's the holistic care that needs to go with lymphedema. You can't just focus on limb volume or limb composition.
No.
It's the big picture, because it's the big picture that's going to influence the lymphatic system, which is going to influence the outcome best.
Yes, along with movement and exercise.
Yes, movement and
help as well.
exercise. You cannot beat it. Every time you move your muscle or something like that, that's helping to pump the lymph or helping to load the lymphatic system and get it away. If we get it away, that means the concentration of all those bad things in the lymphatic system are reduced. And that means those bad messages are not having an effect.
So I suppose encourage them to think that they're helping their lymphedema, even if they're not noticeably losing as much weight.
Yes, the weight's important, but it's what's going on with their lymphatic system and their tissues that are going to be very subtle at first. So don't look at someone who's lost a lot of weight because they've gone to a gym, but concentrate on what you've done. And like I said, number one, if you can slow it down or stop its progression, ask them to reflect back on the last year. How's it gone? How's it been developing? And if you've made a difference to that, wow, you are making a big difference already.
And I guess it doesn't matter how much the exercise. It could be a small thing that they're changing. It doesn't need to be suddenly being able to go out for a big long walk or a run or something like that. She said the gym, it just could be a wee small change, like just moving a little bit more.
Small things
makes a
make
huge difference.
Small things make a big difference. As I said in the talk today, 5 mils per hour is the amount of lymph that drains out of our arms, for instance. And if you can change that in a day, 5 less mils or 5 more mils, you're making a difference to that arm, to that part of the body.
Yeah. Thank you. I appreciate that. Thank you.
Last week I had a patient come in to me with a large arm, and she asked why we can't just put a needle in the arm and draw off the fluid. I wonder if you can explain why that would not be
That's a
possible,
very,
please.
very good question, because Rachel, one of our patients many years ago, used to in fact do that. When their pain level got so high, they would stick a little needle in and the lymph would leak out of their arm and the pain went away, that pressure, that tension went away. Not a good idea. She got an infection in the end, which is pretty serious and significant. However, you can't do that because every moment of our life, everywhere in our body, there's fluids leaking out of our vascular system which can't get back into it. And they have to be taken away via the lymphatic system. And when it's going back up your arm, that's got to be taken away, okay? And yes, you can make a hole in there and you can take it away, but you've got to keep on doing that for the rest of the day, for the rest of the year, the week, the rest of the year.
Yeah.
And you're losing proteins, you're losing fluids, you're losing all sorts of things. So you can't keep doing that. You'd have to do it forever because it's not going to ever stop.
Yeah, I think Professor Mortimer explained it to me once, that it was more like squeezing a sponge than popping a balloon. You know, which I think is something that patients can visualise and understand, that kind of analogy.
Yes, yeah, the fluid's going to keep on coming.
And later on, it won't be fluid. It'll be firmer tissue that isn't going to leak out anyway.
Yeah. So it's not a wise thing to do.
No.
And it certainly won't have any beneficial impact. And the most negative thing is the risk of significant infection. And I guess you look at a similar situation where patients spontaneously leak fluids. You know, you have your clear straw-coloured lymph leaking out along a line of weakness, a fistula or a hair follicle, along a hair follicle or something, or you have the chylus fluid leaking out, the creamy fluid leaking out. You know, you can't let that leak out for any long period of time either, because you're losing it. It's not being recycled through our liver, our kidney, our body, and being reused and reutilised again.
Thank you.
So in terms of training that healthcare professionals might go through to become lymphedema specialists, Neil, do you think enough emphasis is put on patient activation, encouraging patients to become self-empowered in their management of their lymphedema?
At the moment, no, I don't think so. I'm a trainer in one of the international courses, and we are bringing in more of the acknowledging the patient as an individual and the patient's needs and linking to them. But yeah, that linkage between the clinician and the patient is not as strong as it could be or should be, simply because a lot of the therapists are not sure about how to do it properly and are a little bit reticent to do it because of what might be perceived as being inappropriate relationships or whatever. And there is perhaps a legitimate feeling that if you're attached to someone and you're helping them through MLD or something for 6 months or 9 months or a year or two and you go, that's a big gap in that person's life because you've left them. But that's what continuity of care and continuity of management is about, is if you're not going to see them after 6 months, then we organise someone to come in gradually and replace them so there is continuity between one individual and another. But yeah, you know, that rapport, that touch, that communication, I think when you're dealing with a patient, even if you're not dealing with, if you're not doing manual lymphatic drainage, even if you're talking with them and feeling them and probing them and working out what's going on, that touch, that communication, that closeness, that warmth is something they often don't get. And yes, it needs to be taught more in all of our courses, or international courses around the world, and it needs to be an integral part of them.
Yeah, and I think, you know, if the patient feels engaged with their practitioner, if they feel like it's a partnership, then inevitably it's going to be more successful.
You do more, yes. I mean, how many times have you been, pushed from one health professional to another in some sort of assessment of your problems that you've got? And that's so frustrating. You talk to one, then you've got to tell them the whole story, another person the whole story again, then another one, and they've all got different beliefs, they've got different knowledge bases, they've got different things they're chasing up. And you think, even for us, it doesn't make you feel comfortable. But can you imagine, I mean, as a trained health professional, it doesn't make you feel comfortable, but can you imagine what it's like for a patient who experiences this, how unsettling that can be?
Absolutely.
And confusing if they're getting conflicting advice from people that they trust, both of them. Which one do they choose almost?
That's right. And that's where we must have communication at the health professional level as well, when swapping between one health professional and another. And that's why we always maintain, here's what we're doing, and these are the reasons why we're doing it. Okay.
Absolutely.
And your reason and what you're doing is going to be different from your reason and what you're doing. But together, there may be a synergy out of it. And the patient may not understand that, but that needs to be communicated, that we're all working together in a holistic sense to get the best outcome for you. But because of perhaps suboptimal training in our training programs, the therapist is not knowing how to do that best.
Do you find most of your consultations, or some of them anyway, is just listening to what the patient wants and their problems, rather than, from my perspective, just measuring, telling them about garments? But mainly, do you tend to find benefit from just listening, and then maybe another consultation would be more proactive into their treatment?
Listening is the only way to learn about the patient. And yes, you can make some notes, but you can't beat the qualitative information you get from listening. I mean, it's nice to have limb volume measurements. It's nice to know the amount of fluid, the amount of fibre and that, but listening and knowing about them, about their history, about the environment they're living in, about their carer, about their partner, that's super, super important.
Yes. Yes.
I think that probably leads quite on to the question I was going to ask. So often as healthcare professionals, we'll hear people labelled as non-compliant, non-concordant, or lacking motivation and self-management. But sometimes you wonder if that's because as a healthcare professional, we've just not taken enough time to set proper goals or discuss what their barriers or challenges. This is a big thing we're asking people to do as a long-term condition. But there are reduced times available for healthcare care professionals in clinics. So do you have any easy good tips, advice that we can do to try and bridge that gap so we don't get this, they're just not, they don't comply with treatment? Because a lot of the times that's not the case.
It's not that they don't, it's not that they're not compliant or don't comply. They may not be able to, they would love to, but they can't, given the instructions you've given to them, perhaps.
Exactly.
So I guess one of the most important things is when you meet a patient for the first time is to know what you can do and let them know what can be done here in your clinic. But also, more importantly, is to know what they would like. What's their problem? Is it the tension in the limb? Is it the functionality of it? They want to get their hand above their head. Is it less pain? Is it less tension? You know? And you can say, well, knowing this is what I'm going to work on. This is what I'm going to target and sequence the treatment on. And I expect this is something that's going to improve first. And they go and do what you recommend, and you might do a telehealth consult a week after and say, how are you doing with the exercise program? Just give them a quick phone call and see how they're going, and they will see, oh, you're still interested in what you're doing, okay, and they're making a little bit of difference. And we always ask, can you keep a diary, just a simple diary about what you did and how you did it and how it feels? And then they can see that things are better, and they can sometimes see that it's not.
They can see the pattern.
Yeah, they see a pattern, and sometimes realise it's not always better, and find out why it's not always better, because then they've got a leverage point to find out how to make it better. But the key message comes back is this is what we're doing, this is what we're recommending, and this is why. But it's based on them and what they would like done in the first instance.
I think there is a huge range. What's important to us as a therapist, or in theory, is not necessarily what's important to that individual. And I think it is, as you're saying, that understanding that and listening. Saying
we're all individuals, and people have different aims, different objectives. You know, that's what's going to help them in their life. Yes, and to feel better about themselves.
Yeah, and I think this book here does that, allows the patient to to know and learn about their lymphedema and how they can take back control. And it's a wonderful way of looking at patients' experiences and patients' comments about various things, and just seeing that diversity of needs and requirements and responses, and feeding in on that. You know, I mean, the most important person in any one-to-one consult is not you, the therapist, it's them, because they're there for you to help them make a difference, and that's what it is. And yeah, when you're helping them make a difference, it might be their carer, like I said, or their partner, or someone else, but it's what they've got and how they can use what they've got to make the biggest difference for themselves on the basis of their issues and problems that's presenting to them.
Yeah, I mean, ultimately they'll have to make choices, and if they haven't got the knowledge to be able to make that choice that's right for them, then they can't make the right choice, and they don't know that unless you tell them. And I think, you know, it is a challenge. I mean, the LSN appreciates more than anyone what a challenge it is with reduced clinic times and waiting lists, and sometimes maybe it's just about working a bit smarter. So when you're doing the measuring, you can still be chatting, can't you?
Yes, exactly.
You know, or like you say, maybe using a phone call rather than a whole clinic appointment or something.
Well, yes, that's a very good way to do it, is the phone call, because it's still got that continuity of care and the communication, and they know you care about them. And you're right, it doesn't take long. And that's become more prominent with since COVID, about the acceptance of teleconsults.
We've all had to find different ways of working.
Yes. And some of the patients will like doing it via Zoom or Teams or some other strategy, but some of them are quite happy just to have a telephone call.
It's about partnership working, isn't
partnership.
it?
That's exactly it. It's a partnership.
Yeah.
We're all in it together in a partnership. And, you know, that's the best way to get this to survive. That's how friendships and relationships survive in a partnership. There's give and take. And we have to acknowledge that on every occasion, and that's the best way for the patient and for the outcomes.
Yes.
And I think it's important as well to make self-management a positive thing. Yes, because I know a lot of people feel that maybe they're being taught to self-manage because the NHS hasn't got the time to give them the care they need, or, you know, it's an alternative to expertise. And any chronic condition, whether that's asthma or hypertension, it has an element of self-management if you want to be in charge of your life and rule it rather than it ruling you, doesn't it?
Life is not just about continuing treatment, it's about treatment and then management in between those treatment programs.
Absolutely.
And
It's also about making sure the patient understands, because people do have information that they give to patients which might be quite standard but might need tailored a bit for that patient. But often the patient, you think the patient understands, but unless you actually ask them or check them.
Yes, I agree. I agree. You need to have that conversation as well.
it's got to be knowledge at their level.
Yeah.
Because some patients can send them off with an arm sleeve, oh, that's fine, and they'll be concordant. But other patients, you need to keep bringing them back in, and have a more of a gentle approach to their care. But to be successful, being slow treating them is more beneficial.
Yes, it brings us back to the point. Listen to your patient. Yes, engage with your patient, but listen to what they have to say.
Yeah, an example of that is application of compression garments. We know what the optimum compression is for a garment for a given condition. However, sometimes the patient or their carer can't get that compression, can't do the donning. So one of the strategies is saying, oh yeah, okay, let's do two garments. One light compression garment after another light, over another light compression garment, and you get the same pressure, but they can put it on and they can take it off. So they're compliant and they're comfortable with putting it on and off. And the like, or you help them with some aid like a don and doffer, so it's easy for them to get it on and off, so they can do it. But you don't just give them a garment and say, go pick up your garment, put this on in the night time or whatever, and leave it like that. There's got to be some instruction with it and some sort of follow up.
So I think as well, if someone comes back and says they've not been wearing the garment, instead of as a healthcare professional just going, oh well, don't want to have treatment, it's actually unpicking, well, what was the problem? And as you say, they're out then helping between the two of you finding a solution that's acceptable to for that patient, because they're the one that's doing it every day. You know, we're just giving out information.
And it is every day. You know, as a patient, I know it's day in, day out. It gets boring. You know, there's no two ways about it, but it's something that has to be done, definitely.
But also the key message is if they can do their best possible job, along with your best possible job,
Yes.
it's going to save them money, it's going to save the health system money, and they're likely to move towards more normalcy for their limb, or an improvement in the subjective or objective measurements of their limb because of that. And
Yes.
you know, that's a big win for them.
Yes.
But we keep on emphasising also that even if your worst day is today, and it doesn't get any worse, that's a big win, okay? Because it's all progressive, okay? So if there's no treatment available or no one else available to help you, we can halt its progression. That's fantastic. But we're looking at reversing it. But halting it is also a big win.
Oh, definitely.
That's something from your talks, that's something I tell my patients, is as long as we stop it getting any worse,
Yes.
we've done our job, and anything else is a bonus if we can
Yes,
reduce it.
I
So
tend
that's
to
from
agree.
so thank you
Yeah.
very much for that. I have got a question, actually, a bit of a random one. With patients who are wheelchair users, what's your viewpoint on using vibration plates for getting them moving, because they can't move their legs? How would you, apart from vibration plates, or what would you suggest for those people?
Yeah, well, we've done a number of trials on massage pads, and getting the right frequency can make a big difference, because vibration is going to vary tissue pressures, and it's going to vary it close to the surface, wherever that vibration pad is, whether it's in the base of the chair or in the back of the chair. And when you're vibrating the tissues, generally the vibration will go through the whole body, especially if you get the frequency right, and that's going to help lymphatic drainage, because the tissue pressure is varying, albeit in a small way, but it's varying, and that's pretty good. Another way for helping patients who are immobile, that's you've seen clinical trials on, is electrostimulation. Those patients who are immobilised in care villages, care housing groups and stuff like that, they're stimulated. They can be stimulated electronically, and that means their muscles contract, or you can change the stimulation a little bit to get them to stimulate their lymph vessels or their blood vessels to contract. And that makes a difference. And that means they don't have to do much, but except it means they know that when they do it, they get a good outcome. They feel better. So, yes, they keep on doing it.
Yeah.
Yeah, and I think, like you're saying, it's a whole body system, isn't it?
Yeah,
Your lymphatic, even if it's only your limb that's swollen, it's the whole of the lymphatic system. So, like with the BLS campaign, everybody can, any little bit, even if I can't move my legs, if I move my arms,
Yes.
that's better than something.
And if I breathe a little bit deeper,
Yeah.
that's going to make
Absolutely.
a difference for me. Okay,
Yeah.
and everyone knows you've taken a couple of nice deep breaths in, and
You feel better.
you feel so much better. Okay, even if it's not significantly moved lots of lymph immediately, there may be some significant improvement in the longer term.
Yeah.
Yes. I mean, I think the campaign's got lots of tips for people who can't do very much, and I agree that the machines, the technical things can help, but they don't need it.
No, it's amazing what you can do yourself.
Yeah.
There are
Yeah.
little things that will make a difference.
Yes, little things make a big
Yes.
difference.
Yes, they do. Yes, they do. Every little bit counts, as somebody said. Well, what a treat we've had. Thank you to Professor Pillar for that really informative session on supporting patient self-management and empowering patients to positively impact their lymphedema. And also thanks to all the participants of the Q&A session afterwards. So good afternoon, I'm Cheryl White. I'm a lymphedema specialist, physiotherapist and a BLS editor. And I'm joined by Rachel Hutton, lymphedema nurse and also BLS trustee. As you can see, this session has taken a slightly different format to the previous webinars this week, as Professor Pillar pre-recorded the Q&A session with members of the Lymphedema Support Network and some of our trustees earlier. So therefore, we will not be answering any questions live, but we'll submit any that we've had to Professor Pillar and answer them
either update the chat or we'll answer them in our newsletter, News and Views. So thank you for attending our final webinar today and those that we've had throughout the week. And thank you to all of our speakers and our sponsors, Haddenham Healthcare, Essity and Juzo, who have helped to make this week so successful. What a fantastic week we've had. Can I remind you that if you've registered for any of the webinars, you'll be able to watch again following the link that's sent in the follow-up email. Otherwise, you'll be able to access the webinars when they're launched on the YouTube channel, probably early next month. If you're interested in joining BLS, you can join as a friend and that's free, or maybe you'd consider joining as a full member, but both grant access to a vast array of information and resources about lymphedema and lipedema, skincare, exercise, and all the elements that you've heard about this week. You just need to visit www.thebls.com and click on membership, and you'll be able to follow the steps there. So BLS has really enjoyed hosting the webinars during Lymphedema Awareness Week. It's been an amazing mix of both clinicians and patients attending from all over the globe. Thank you once again for watching and contributing with questions and discussion, and we'll be following up anything outstanding from the week in the newsletter, as I've said. Our next event is the extremely successful annual conference in October, and the venue's at Chester Racecourse this year. And so we hope to see some of you there. Again, look on the BLS website for details or follow the links on social media. So that's it. We're signing off now from Lymphedema Awareness Week, and we're so pleased at how successful it's been, and thank you again for joining us. So it's goodbye from myself, Rachel, and the rest of the BLS team. Goodbye.
Bye.